Hello. Let's talk about tumors, specifically tumors of the head and neck. This is a visual SDL, and it's very detail-oriented. And for all of these questions, the clinical diagnosis is going to have already been made for you, meaning they're going to tell you where the tumor is, and you're going to have to choose between a differential of some grossly similar but internally different tumors. And then the questions are also going to be about things like second tumors. Where could another tumor rise up? Where could a metastasis rise up? There's a little bit of genetics in this lecture, not a lot. Mostly it's anatomical, identifying things based off of where they're presenting and making a differential based on some very minor anatomical and histological details. We start off with odontogenic cysts. Odontogenic means starting from the teeth, odonto meaning teeth, genic meaning rising up from. A cyst is a pocket of pus, essentially. Now, a cyst can be just benign fluid or proteinaceous exudate, as is the case with a ganglion cyst, but these cysts are inflammatory cysts, meaning that there's pus inside of them. And anytime you see pus, what is pus? Dead neutrophils and the liquids they produce. So the central liquefaction in these odontogenic inflammatory cysts is due to neutrophils and their proteolytic enzymes. There's a couple of types of cysts that can grow up around your teeth. One of them is the radicular cyst, and we've heard this word radicular before, and we've heard it in block 3, neuroblock, in reference to radicular pain or radiculopathies, right? And so that's going to be nerve root pain. And radicular compression in the spinal cord is, well, whenever you have two vertebrae and they're squeezing down on a nerve root and impinging that entire root and the entire dermatome, myotome downstream from that rootlet. So radicular means involving a root. And when we're looking at the teeth, the root of the tooth is going to be basically the bottom of the tooth. Let me highlight that for you right here. That's a radicular cyst. And specifically, that kind of pointy, apical looking part of the tooth, that's the root of the tooth. So a radicular cyst forms a pocket around the root of a dead tooth, a non-vital tooth. And teeth can die. Teeth are alive, very alive, even though they're hard as a brick. You know, they've got a blood supply and they've got a nerve supply. And so an infection or a traumatic incident to a tooth can cause it to die if it is cut off from its blood or nerve supply. So when a tooth dies, that's called a carie. And following a dental carie, you can get this inflammatory cyst as a byproduct of all the cell death in the area. So that's why you get neutrophils at the root of a tooth, because you shouldn't normally have a bunch of neutrophils. But then we know that the cyst is filled with pus, and the pus is from neutrophils. So how did the neutrophils get there? The tooth dies. So on histology of one of these cysts, you just see central liquefaction necrosis. And the liquefactive necrosis is due to the proteolytic enzymes released by neutrophils. And it's going to be surrounded by a squamous epithelium. So moving into odontogenic cysts. Developmental odontogenic cysts. So that means it's not acquired. What we just looked at was an acquired cyst around a tooth. And now these are going to be latent or endogenously acquired cysts around a tooth. You got two types. You've got a dentigerous cyst and you've got an odontogenic keratocyst. So the dentigerous cyst, well, we just looked at a cyst that was around the root of a tooth. Well, now we're looking at a cyst that's going to be around the crown of a tooth. So this is an easy diagnosis to make. It's always going to involve the top of an unerupted tooth, meaning it's still down inside the bone of your mandible. Typically, it's going to be one of your very back molars, maybe a wisdom tooth. And the cyst is connected to the cemento-enameled junction of the unerupted tooth, which is basically the midline of the tooth. It's this kind of artificial, not really artificial, it's a histological line connecting the top to the bottom of the tooth. And once more, the cyst is lined by a squamous epithelium. It's important to note that this is going to be a unilocular cyst, meaning it's just one pocket, one packet of fluid. And our last type of odontogenic cyst, or a cyst around the tooth, is the keratocyst. And this is going to be a multilocular cyst most often, meaning it's going to have many different pockets of fluid connected to one another. So it's going to look more so like a cluster of grapes rather than just one grape itself. These occur in young adults and they are highly associated with pain. They grow up in the jaw, although they can present in the maxilla. Here's your histology. Once more, all throughout this lecture, you get the histology of every single cancer. The questions are going to all have histology attached to them on the exam. So you need to start parsing things apart based off of what's different about their histologies. And in the case of a keratocyst, what's particularly different about it is the fact that it is multiloculated. So again, we're looking at a large cystic area here, but it's not just one cyst. You can tell by the opacities on this model that there's multiple packets and folds and chambers to this cyst. So that's what's differentiating it from a developmental cyst around just one tooth. Important to remember what Gorlin syndrome is, nevoid basal cell carcinoma syndrome. And that's because odontogenic keratocysts are associated with this basal cell carcinoma syndrome, which is inherited in an autosomal dominant manner. And patients with Gorlin syndrome present with lots of dots, typically all over their face. It can be elsewhere on their body. And the dots are referred to as blue nevi. And then they're prone to basal cell carcinomas, which is a pretty bad type of skin cancer. The only skin cancer that's really worse is a malignant melanoma. And the basal cell carcinoma has a high metastatic rate. And Gorlin syndrome patients also get these cardiac fibromas and ovarian fibromas because of the patch1 mutation. Patch is expressed in the connective tissue of the heart and reproductive organs. And patch is a tumor suppressor gene. It's part of the hedgehog signaling pathway, and we know that the hedgehog proteins are going to be basically like directional instructions for developing cells, right? So when you've got a cell that's still a stem cell, right, and it's kind of growing into its final terminal differentiated form, well, it receives instructions that specify where and how to grow. So it's kind of like these cells get like commands from proteins, like up, down, left, right, you know. And so the hedgehog protein is a particular chemotactic protein that's going to make cells grow in a particular direction. So when that's not there, then the cells just stay in place. And when that happens with your connective tissue and mesenchymal cells, mesodermal type cells, well, then you just get this big fibrotic type of ball. So here is a keratocyst. And this keratocyst is multiloculated, and it's differentiable from the two cysts we've previously talked about, because those are going to have just a thin squamous lining with no keratinization. But then the keratocyst is going to have keratinization, and keratin is a very tough surface protein of epithelial origin. You've got keratin in your nails, on the surface of your skin. And so the fact that this epithelium is keratinized just means that it's particularly thick, and that towards the top, you're going to be able to tell that the squamous cells start to flatten out in shape and start to pancake. So here's another look at that. And again, you can tell that at the periphery, or at the outside of that squamous lining, the cells are starting to pancake, and it's the keratin that they're expressing that's helping them to dry up and flatten down. And then you've just got a bunch of fibrous tissue underneath it. So this thick epithelial margin, plus the fact that it is multiloculated, is what makes you suspect keratocyst specifically. Here's Gorlin syndrome. Again, it's the patch 1 mutation on chromosome 9. It's associated with multiple basal cell carcinomas, multiple nevi, patches, dark patches of skin tags, basically. Here's a good example of one right there. And in conclusion for this section, just want to review where a basal versus a squamous cell carcinoma comes from, right? So you've got 5 layers of your skin, and they're called stratums, right? Like stratospheres. And the deepest stratum of your epidermis is the stratum basale, and that is your basal cell layer, and it's called your basal cell layer because it's at the base of the epidermis. And so right underneath your basal cell layer, you have a basement membrane, and the basal cells are going to be round and kind of cuboidal in shape. And as cells break off from the basal layer, they move upwards in the skin, and they form your other stratums, culminating with your stratum corneum, I believe, at the very top. And that's going to be just flat squamous cells. So the basal cell layer is going to be a divisional layer, and cell division takes place there, and these cells crowd each other out and move towards the surface of your skin. And as you know, your skin is always replacing itself. So a basal cell carcinoma is going to be a acquired mutation leading to neoplastic clonality within a cell anchored to the basal layer. Whereas a squamous cell carcinoma is going to be the same thing. A cell turns cancerous, but it will have already detached from the basement membrane. And so a squamous cell carcinoma is going to happen to any cell that's already detached and is on its way outward. But then a basal cell carcinoma is going to be any of these cells that is still tightly attached down here. And basal cell carcinomas are worse prognostically because they still are dividing. They're not terminally differentiated, because the squamous cell, that's the terminally differentiated cell. You can't turn a squamous cell into anything. It's going to be gone in a week. It's going to be off the surface of the skin. But a basal cell, that's got replicative capacity. And so it can obviously lead to a much larger tumor mass than a squamous cell, because it is capable of dividing so rapidly. And then on top of that, well, what's immediately underneath the basal cell layer? The dermis and the blood supply is right there too. You've got a lot of veins just right underneath that basement membrane that the basal cells sit on top of. And so if a basal cell carcinoma acquires a mutation that allows it to perforate the basement cell membrane, maybe it acquires a protease, or it starts making proteases, or maybe it makes its environment really acidic due to the Warburg effect, which is going to be anaerobic glycolysis, which generates lactate. So maybe a cancer is going to induce some necrosis in the regions and localities surrounding it, and that necrosis makes your basement membrane permeable. And then you take one region of basal cell carcinoma and it extravasates down into the dermis, and then it has access to your blood supply, and that's how a metastasis can occur. So that's why basal cell carcinomas are worse than squamous cells, and that's where they come from. Back to the text. Now we're looking at Odontogenic tumors. So let's wrap up what we just talked about. Odontogenic cysts. They're acquired, right? And they can be a developmentally acquired cyst, so you can kind of be born with a predisposition to these cysts. But at the end of the day, a cyst is a packet, a pocket, a chamber, but a tumor is a mass. So that's what we're talking about now. Odontogenic tumors, masses that are found around the teeth, not pockets of fluid that are found around the teeth, masses that are found around the teeth. The first type that we'll talk about is the ameloblastoma. It's technically benign, but due to its location, it can start to grow and encroach upon some important nerves and cause some really bad symptoms and a lot of pain that way. It grows intraosseously within bone, typically within the mandible, at the angle, the body of the mandible, the ramus. This is also going to be a multilocular mass. It's not a multilocular cyst. It's a multilocular mass, but like the keratocyst, it is multilocular. And remember the first two cysts that we talked about, the apical rootlet cyst and then the dentigerous cyst at the crown of the tooth. Both of those were unilocular. So to understand where the ameloblastoma comes from, it helps to know what an ameloblast is. And an ameloblast is particularly a cell that makes enamel. And they're very highly active whenever your teeth are forming. So throughout childhood, right? You have baby teeth, you push them on out, and then you replace them with adult teeth. And so up until the point where you've got all your adult teeth, you've got some ameloblast activity. And the ameloblasts are going to sit on top of a layer of enamel. And then when a tooth is all done forming, ready to go, right? Ready to roll off the lot, the ameloblasts just die. They're done. And then you're left with enamel on the outside of a tooth. But until that enamel's done forming, you've got ameloblasts on the outside. And this is whenever a tooth is down within the gums, right? So the ameloblasts are going to be this palisading layer of columnar fan-like cells sitting on top of this deep pink-red strip of enamel within the slice of this developing tooth. So that is the cell that an ameloblastoma originates from. Here's what it looks like again, a little bit zoomed in. It's a large, expansile, multilocular lesion. It's a mass lesion, and it's going to be well demarcated, meaning it's got clear boundaries. You can tell the tumor stops there. You can tell the tumor stops right there. It can be unilocular in its early presentation. And here's an example of one over here, right? And you can very clearly see, here are the boundaries of a mass. And then you've got an opacity looking like a pre-developmental tooth stuck up in there. And if you look in at the histology, you see cells that look very similar to ameloblasts, right? So if these palisading cells are the cancerous cell, well, then you look at the tumor and it's going to look very similar when it's well differentiated. Palisading basal cells, essentially that means ameloblasts, and they're very columnar. And right here is a good row of them. I'll use blue, it'll stand out better. There we go. So there's the inner layer. Here's an outer layer of ameloblasts right there. And you can tell that although the cells look relatively normal, the macro structure of this tissue is pretty distorted and non-uniform, disorganized. Here's another example again, like knowing that these are ameloblasts, just based on where they tell you the lesion is in the mouth, you're going to say, okay, you should only see ameloblasts on the surface of a tooth. So you're seeing a nest of them here. So that means that there's just way too many of them. So let's get back to the text. remember that the ameloblastoma is a benign tumor, and you've got these columnar basal cells that palisade, and they're going to form nests. Getting into what sort of questions could they ask you when given a diagnosis of ameloblastoma? Well, they could say, what's the gene involved? And typically it's going to be BRAF. That's the most common one involved. But really, any mutations in the MAP kinase pathway are going to lead to a higher predilection for the ameloblastoma. MAP kinase pathway is going to be an activating pathway that gets cells to grow and get through the G1 phase of the cell cycle pretty rapidly. More MAPK means quicker cell division. So that's why you see a bunch of ameloblasts, is because they're hyperactive. This is an oncogenetic pathway, not a tumor suppressor gene pathway. So we will specify that and then tack it onto the side here, because that's a favorite line of questioning. You can get a metastatic ameloblastoma, or you can get an ameloblastic carcinoma. And both of these can metastasize to the lungs. So this is a little bit tricky. They're trying to throw a fastball by you, because a ameloblastoma that metastasizes is going to retain its benign histological appearance. But a ameloblastic carcinoma is histologically going to be a lot more messed up because it's a malignant cancer. So if you get a patient with the tumor in the mouth, the multiloculated mass in the mandible, and then you've got a metastasis to the lungs, right? Well, then you biopsy the lungs, and that's kind of where I'm thinking the question is going to come from. And then it's going to say something like, what's the diagnosis, you know? And you're going to have to recognize the degree of dedifferentiation or atypia within the cellular specimen to get the question right. So here's what an ameloblastic carcinoma looks like in the mouth. Obviously, it's big, it's bad. You can tell it's multiloculated. It's got multiple kind of body parts to it. And then you zoom in on it, and it's more dedifferentiated than an ameloblastoma is. And you can tell this because it's got these big popping nuclei, right? With not a lot of cytoplasm. So this is called cellular atypia, right? And that's going to be an indication of cancer. Malignant cancer specifically. The greater the degree of atypia, the worse the prognosis for the cancer. And let's go back to the ameloblastoma one more time and say, remember what we said. The architecture of this region is pretty messed up. Like, there's way too many of these cells, but the cells themselves look relatively normal. You know, they look like how ameloblasts look, versus these cells that we're getting into now. Well, these do not look like ameloblasts. Ameloblasts are tall and columnar, right? And what are these things? They're round and inflated with, again, really large nuclei, and then some of them are whirling up around one another. So this is dedifferentiation that you're observing, which means that the cell is changing shapes to a shape that it doesn't normally occupy. And then you will also see some necrosis with a ameloblastic carcinoma, because necrosis, again, is more necrosis, worse prognosis for the tumor. And the necrosis here is represented by this zone in the middle. And necrosis is most evident on histology by acellularity or anuclearity, meaning a lack of live cells in an area. And so because you look at this region and there's like, I mean, you can count the number of cells that you see there on 3 hands. It's like there may be 15 individual cells in this really big space. And so where did the cells go? They died. So that's your ameloblastic carcinoma. Let's get back to the text. In review, there's a good solid paragraph on the histology of an amyloblastic carcinoma, and goes out of its way to mention that both the carcinoma and the benign ameloblastoma may metastasize to the lungs. So that's where I got to feel the question from that section is coming from, if there is one. Let's talk about a calcifying epithelial odontogenic tumor, or a CEOT. So because it's a calcifying tumor, it makes sense that it's got a lot of calcifications histologically. And calcifications are going to appear variably depending on the stain. But what you got to understand is they're always just going to look like big blobs or rocks or geodes, you know, like it's going to look like a big rock in the middle of a bunch of cells. And it being an epithelial tumor means the tumor cell, the lineage of cell that turns cancerous is going to be an epithelial cell. And then odontogenic means that it's going to pop up around the teeth. So it starts off by really giving you the location and the histology, just like everything else here. Posterior mandible. Then it tells you what it looks like under a microscope. We talk a little bit about the presentation, but again, the presentation is going to be given to you in a question stem, you know. We talk about the imaging, and this might be associated with an unerupted tooth, okay? So don't mistake it for a cyst. Understand it's a mass, not a cyst. That's going to be your first differential point there. Is there fluid? Is it a mass? And then large calcifying epithelial odontogenic tumors are going to be multilocular. And a really big differentiator of this specific tumor is, put it in blue so it stands out, intratumoral calcification. So if you get a radiograph of a lesion in the jaw and it's just lit up white, right? Then you're going to be suspecting calcifications within that mass, because calcifications are opaque on an X-ray. So that's what's unique about the CEOT. Let's quickly look at the histology. It features sheets of large polyhedral epithelial cells with abundant cytoplasm and prominent intercellular bridges. So polyhedral means it looks like a 20-sided die. And if we zoom in on these epithelial cells in this picture on the left here, you're going to see what we're talking about. Go green. Where they've got this kind of funky hexagonal type shape to them, you know? And they, like, this one's shaped like a trapezoid. Then this one's got like 1, 2, 3, 4, 5, 6 sides, yo. Yeah, and like this one too, it's also shaped like a pentagon or a hexagon. So these epithelial cells have these wicked shapes to them, yo. And then of course, like, there's your calcium right there, you know, big old calcium rock in the middle of a bunch of cells. So that's what they mean when they're talking about polyhedral epithelial sheets. And up here in the top right here, this pink stuff here, big old crystal, calcium, bunch of calcium. It's a solid rock. And you see these polyhedral type of epithelial cells around it. So the epithelial cells are blown up and they've got some big nuclei to them. They're going to be inside the jaw, and they're going to have a calcium crystal on histology. Let's get back to the SDL. Odontoma. An odontoma is a benign odontogenic tumor arising from odontogenic epithelium and having mesenchymal elements. These are hamartomas. A hamartoma is not a neoplasm because there's really no cellular atypia in a hamartoma. There's no unique changes in individual cells, but there are changes in the macrostructure of a tissue. There are changes in the architecture of a tissue. So normal cells arranged abnormally, meaning there's too many of them or they're not connected correctly, but the parts are normal, the cells are normal. We've got two types of odontomas. They're compound and complex, and these are, I'm thinking odontoma, that basically means tooth tumor. So these are going to be tumors that look like teeth. And so the compound type of odontoma is going to look like a lot of small tooth-like rocks. But the complex odontoma is not going to look like a tooth whatsoever. It's just going to be a twisted, convoluted, distorted mass. So what's the risk factor? Delayed eruption or impaction of permanent teeth. So you should have tooth popping up, right? You lose your baby tooth, you're expecting a normal adult tooth, but tooth never comes in, and then maybe you're like 22 sitting around on a Sunday, and you're just like, well, I wonder why that tooth never came in. So you go to the dentist, and the dentist takes an x-ray, and then holy cow, you got like 5 rocks up where your tooth should be, you know? And so what is that? Compound odontoma, or complex. That's basically all you got to know about it. It's a bunch of rocks that grow where your teeth should be. Here's the compound one. Again, you zoom in and you can tell lots of little rocks there. Lots of little rocks. You got 1, 2, 3, 4. You can tell 5 down there, right? You got maybe like a 6th one in there. So little tiny pebbles versus the complex odontoma, which is one giant boulder, okay? So that's your differential. Again, they grow where your teeth ought to be. And looking at a nice, colorful histological section, the complex odontoma, well, start with the compound one. Compounds look like teeth. Again, they're tiny teeth. They're just hamartomas. So you can tell that this structure has the general shape of a tooth, right? It's got some enamel layer. It's got a lot of dentin, and that dense pink is mineralization. And notice it looks a lot like the calcium crystals that we just looked at. This dense pink is taken up stain because it's a mineralized structure. And you got a lot of dental pulp down here. A lot of mesenchymal tissue in that dental pulp. So it looks like a tooth, right? Hasn't really lost its toothiness. But a complex odontoma, no, that does not look like a tooth. That looks like a war zone, right? So it's a disorganized mass. You're going to see enamel here, enamel there, dentin here, dentin there. That's the gist of it. Okay, moving on into the nose. This is probably the toughest section of this SDL because a couple of these have variants to them. Let's talk about polyps first and foremost. I want to start by saying that if you have a pediatric patient with a polyp, then the very next thing that you ought to do is get a sweat test on that patient, because polyps in kids are very rare and highly associated with cystic fibrosis. Second thing I want to say is that the most common cause of polyps in adults is going to be allergies, typically seasonal allergies, but it can be something a little bit more specific than that. Polyps can also be associated with asthma. And when polyps are associated with asthma, you ought to check to see if the patient is on NSAIDs, because NSAIDs block cyclooxygenase. But the cells of your nose, even when cyclooxygenase is blocked, well, if you remember your arachidonic acid metabolic pathway, cyclooxygenase turns arachidonic acids into prostaglandins and thromboxanes. But there's a different enzyme that's not cyclooxygenase that makes these things called leukotrienes. And so COX isn't necessarily going to make all the swelling go away, because you can still make leukotrienes in a setting of inflammation when there's arachidonic acid. And so that's what will happen to these patients is they'll take NSAIDs and they'll have a polyp, and because they have this polyp, Well, they take the NSAID and cyclooxygenase gets inhibited, but because they're making leukotrienes, their airway still swells up, right? And so their airway swells up, and that's how they get this asthma. And there's an allergy component involved too. That's why it's asthma. But I want you to be aware of that interaction for when we do get into the asthma SDL and talk about it farther. So polyps are most often a consequence of chronic inflammation, and you typically see a lot of eosinophils on biopsy. And eosinophils are there because cells are releasing a lot of interleukin-5, and that's your eosinophil magnet cytokine. And what do eosinophils do? Well, they're leukocytes, which means they're white blood cells, and they're created in your bone marrow. And eosinophils are involved in the anti-parasite immune response, and they're also involved in the response against a lot of fungi. And their most characteristic role in the body is to participate in allergic reactions. And so whenever you do have allergies, you can have antibodies produced against specific allergens, because allergens are going to be allergy generators, and the way they generate an allergy is because they're also antigens, and so they generate antibodies because your antigen presenting cells like a dendritic cell or a tissue macrophage is going to pick up an allergen and present it on major histocompatibility complex to a B cell, and the B cell is going to make antibodies that are shaped similarly to that antigen. And so when the B cell does this, well, then those antibodies can activate eosinophils. And when eosinophils participate in the allergic response, it helps to establish a memory to that particular antigen. And that memory that can get triggered by that antigen, that's the allergy. So nasal polyps are highly involved with allergic reactions. You see a lot of eosinophils. They most frequently arise from the mucous membrane of the ethmoid sinuses and prolapse into the nose via the middle meatus. So if you remember, you have a superior, middle, and inferior meatus. You have superior, middle, and inferior turbinates or concha in your nose as well, and those are your bony shelves. And whenever you're doing an endoscope of the nose, you're going to see the nasal septum along the midline. There's only one of those, and then you're going to see 3 shelves going top, middle, bottom on both sides, and those are going to be your concha. And then the meatuses are going to be holes in between each shelf, next to each shelf. And so these sinuses, or these polyps, start in the ethmoid sinus, which is in your ethmoid bone, which is a midline structure, and it's going to be right behind your nasal bones and right behind your frontal bones there. And the ethmoid sinuses there's one on each side, and remember, they're on the medial inferior surface of that orbital cavity. And so a polyp can originate from within that sinus and grow into the major nasal cavity through this middle meatus. So I'm spelling out all the anatomy because the location of nasal tumors is very, very, very important. All of these tumors discussed in this SDL have a characteristic spot somewhere in the nasal cavity and sinuses that they like to originate at, that they frequently originate at. And so I know real life isn't like that. You know, just because it's arising from the middle meatus does not mean it's automatically this type of polyp, but for our basic tiny little OMS1 minds, it's a normal nasal polyp. So if it's an adult, it's probably an allergy. Symptoms are obvious. They're going to give you the symptoms. Pathology, it's got an epithelial surface. It's got a respiratory epithelial surface most commonly, and we haven't really talked about the respiratory epithelium yet, but you need to know that you've got ciliated cells and goblet cells and basal cells. And those are your 3 big cell types, and the basal cells are shaped like tiny little pyramids, and then the ciliated cells are shaped like long columns, and the ciliated cells are like the big inflatable balloons at the car lots that just go like that all day. You know, those are your ciliated cells. And so the last cell is the goblet cell, which is basically just a reservoir of fluid. So Whenever you see those cells in combination, you're looking at respiratory epithelium, and then underneath that epithelium, you just see general loose connective tissue, and that is a nasal polyp. So here's what we're looking at. We've got respiratory epithelium right here. We've got a thick basement membrane. So the basement membrane is going to be, I'll trace that with a dotted line right here. There's your basement membrane. It's whited out and it's anuclear, right? And so when we're looking at this, you can follow the basement membrane all the way up, like along that pathway, correct? And you notice there are no cells in it because there's just collagen there. There's just fibers there. It's just there to be an anchoring strip. So let's zoom back in on our respiratory epithelium. Every whited out cell that you're going to see up here, that's a goblet cell. And the reason it's whited out is because goblet cells secrete a sugary mucus. There's a lot of sugars. They're glycoproteins. And so whenever you go to prepare a slide, you have to prep it with formaldehyde, and that's a polar solvent. And because it's a polar solvent, you wash out polar material from these very thin goblet cells. And so everything that's inside those cells just goes bye-bye whenever you prep a slide. So that's why goblet cells present with this really light, snow-colored, fuzzy appearance on histologies because the sugars in them just got washed out. What else do we have? Ciliated cells. Yeah, you know what ciliated cells are. And then we see a lot of lymphocytes in this upper triangle of the old histology. Dang. Trying to get a big, thick marker. There we go. Yeah, right up here, you see we're seeing a lot of lymphocytes. And the lymphocytes are just these tiny little cells that look like purple dots. And they don't have a lot of cytoplasm to them because their nuclei are pretty big. So that's a nasal polyp. Here's a nasopharyngeal angiofibroma, which is a little bit worse than a polyp, but it's growing out of the same region where you would expect a polyp to be growing. So I've included this endoscopic angle. And if you notice here, the nasal septum is on the right side of this image. So that's how you know you're looking at a right nostril, right? Because you're going to orient yourself based on where the septum is, and that's going to be the midline. And then so you're going to look next for your turbinates, and you would probably not be able to know that this is the inferior turbinate were it not labeled, you know, like, because who's saying that's not the middle turbinate, you know? But that's what a turbinate looks like from the outside in. And then right here, J and A, that's your juvenile nasopharyngeal angiofibroma that is intruding into the nasal cavity from the sphenopalatine foramen. So it's growing kind of at a 45-degree angle from the floor of the nasal cavity upwards, like up and out. That's the direction that this angiofibroma is growing. And then if it were a nasal polyp growing from the middle meatus, it wouldn't have that upness to it. It'd just be going straight through the middle meatus, right? And so that's what these tumors look like inside the nasal cavity. They prolapse or grow through holes and protrude into the nasal cavity, although some of them we're going to see do grow from the surface of this nasal mucosa. So let's get back to the text and discuss this nasopharyngeal angiofibroma quickly. It's a benign tumor, but although it is considered a benign tumor, it's locally aggressive because it's in a bad spot, you know, because what's right behind your ethmoid bone and your sphenoid bone? Well, your cavernous sinus, and your pituitary gland, and a whole big plexus of veins, and you've got 2 internal carotid arteries back there too. So anytime you get a mass effect in this territory, it's dangerous. So the nasopharyngeal angiofibroma, without even reading anything about it, you can tell it's going to be in the nasopharynx, and it's going to have a blood vessel component, angio, and it's going to have a fibrous component, fibroma. So let's look at a picture of it quickly. Look at that. You've got an angio component. Look at all these blood vessels. Look at all these blood vessels. That one's a venule. It's even got some blood cells inside of it. Look at all those blood vessels. Then it's got a fibrous component too, and it's this wavy stroma, you know, that looks like a Van Gogh painting, just kind of woo, woo, woo. That's fibrous tissue. Anytime you see it, that's a bunch of collagen that's nested, folded up in itself. So this is an angiofibroma, obviously. What's important to know, because it's characteristic about this type of nasal tumor, is it's a hamartoma too. Now, we talked about an odontogenic hamartoma. That was your odontoma, right? But this is a hamartoma in the nose. Remember that we said a hamartoma's got normal looking cells. The cells look normal. The tissue is what's messed up. But you zoom in far enough and it's like, well, looking at this slice, for example, there's nothing particularly wrong about any of these cells, you know, they just look like normal wavy fibroblasts. And you look around the blood vessels and there's nothing wrong with those endothelial cells, you know, they're not blown up, they're not necrotic, they're not like wildly mitotic. So nothing about the microstructure of this makes you think cancer, but then you zoom out and you're like, okay, that has to be some sort of mass lesion just because there's so much fibrosis there. So that's your nasopharyngeal angiofibroma. Back to the SDL. This is a source of nosebleed. Again, with words, what we just looked at is plump fibroblasts, generous amount of connective tissue, lots of blood vessels. So that's it. The only thing you can get really questioned on is where is it? Again, the location, sphenopalatine foramen, and what is it? And the answer to that is it's a hamartoma, and it's not a true neoplasm technically. So let's talk about SSPs, sinonasal Schneiderian papillomas. It's called Schneiderian because the Schneiderian endothelium or mucosa is what this tumor grows out of. It's a papilloma, meaning it's going to have like fronds or finger-like projections to it. It's going to be shaped like a sea anemone, kind of. And it's a benign neoplasm. May originate from either the nasal cavity or the paranasal sinuses. So what's important anytime we're breaking down a tumor SDL? Where does it start? What's the tumorous cell type? What's the histology? So let's go through those three things. You've got three variants of your SSPs: fungiform, inverted, and oncocytic. Now, fungiform papillomas are going to typically grow straight from the nasal septum. So that's important because these other two do not start from the midline septum. And so going back up and looking at this slide right here, you notice the septum is, there's one septum and it's midline. So if you see an endoscope and something's growing out of the septum, you're going to recognize the septum really handily. So that's going to be your fungiform SSP or sinonasal papilloma. Now, these other two, the inverted and the oncocytic papillomas, like to grow out from the lateral nasal wall and the paranasal sinuses. So how are they going to present on an endoscope? Well, they're not going to be on this side of things. They are not going to be over here on the septum. No, 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 no. They're either going to go, they're going to grow straight out from this mucosa over here on the lateral wall, right? Or they're going to do what this angiofibroma is doing, and they're going to start from inside a sinus and grow through a meatus. And obviously that sinus is going to be so blocked, you're going to get a head x-ray or a head CT, and that whole sinus is just going to light up. You know, it's going to glow because there's going to be so much snot in there that, man, this kid's going to have a pound of snot up in there. So it's not a nice tumor because it doesn't really feel good to be walking around with your head like that. So you want to resect these as often as possible. The polyp is the one, specifically the adult allergic polyp is going to be the one of these that you want to treat first with glucocorticoids because it's not typically going to grow very fast, and so you want to see if you can curb it chemically at first. But these omas, yeah, get them out of there, I'd say. Let's go back to the SDL quickly. So we got 3 types. Fungiform, inverted, oncocytic. Because these are papillomas, they are all associated with human papillomavirus. Imagine that. Now, 6 and 11 like to cause polyps. 16 and 18 are the very high-risk human papillomaviruses, I recall. And there's a lot of other types of HPV. And my understanding is that we've got some pretty good HPV vaccines now for specific types. And because HPV is one of the most common sources of genital warts, we're encouraging kids to get that vaccine, teenagers to get that vaccine. And from what I understand, it's doing a pretty good job so far of curbing the rates of HPV, which is really good because HPV loves to be associated with cancers, all types of omas all throughout the body. So this sinonasal papilloma, because it's a papilloma, you're putting 1 and 1 together and you're saying HPV association. And it says they're also Epstein-Barr virus negative, and Epstein-Barr virus can cause a lymphadenopathy. It can cause a nasopharyngeal carcinoma, specifically in Asians, and it can cause lymphomas, 2 B-cell cancers, which may present up in the nasopharyngeal area because there's a lot of lymph nodes up in there. And so Epstein-Barr, the etiology of Epstein-Barr is certainly in play anytime you discover a mass lesion within the pharynx. SSPs are locally destructive with a marked tendency for recurrence and malignant transformation. And specifically, they like to grow into squamous cell carcinoma, which is bad, bad, bad because of its anatomical location in this case. Again, right in the middle of your skull. Now, we said earlier, normally squamous cell carcinomas are pretty benign because they don't metastasize, right? Well, that's on the skin. You get a squamous cell carcinoma inside your skull, you know, or like inside the lumen of a tubular structure, and that's a one-way ticket to obstruction. So that's the type of representation you can see following a sinonasal papilloma. Let's wrap up this section by breaking down the 3 subtypes histologically. You've got fungiform papillomas, which are exophytic. And exophytic has a buzzword associated with it, and that buzzword is like cluster of grapes, okay? And so exophytic means that it's got finger-like fronds on the outside of it, right? And then if we zoom way in, you can tell that the epithelium of this papilloma has got bumps all over it, right? It's a bumpy, lumpy epithelium. And even it's got small bumps on large bumps because it's like, that's a large bump. That's a large bump. Like, that's a large bump. But like, yo, these bumps have bumps. That's how bumpy it is. So that's your fungiform papilloma. It's exophytic and the bumps are on the outside of the tumor. An inverted sinonasal papilloma does not have bumps on the outside of the tumor. Instead, it has bumps on the inside of the tumor. So let's zoom on in. Notice we've got a flat exterior. It's bumpy, but it's squamous on the outside. That'll help you differentiate it. And it's pretty squamous on the inside too. But what you're seeing with all of these outline shapes here, you know, like here's a cluster of just outlines. What you're seeing are the same bumps as are on the outside of this fungiform papilloma, just inverted and turned on the inside. So the analogy for this is a sock, and this is the same sock folded inside out. So that's what we're looking at here. Inverted papilloma is characterized by endophytic growth. That's the correct terminology for it. Growth inwards, finger-like growth, that's the phyticness, and then endo, inwards. Growth of epithelial nests with a smooth outer contour, again, because they're epithelial cells on the outside. And it even mentions that in the SDL that Schneiderian mucosa is of ectodermal derivation in contrast to the mucosal lining of the nasopharynx, which is endodermally derived. So that's why, okay, this one has a bunch of squamous cells, flat cells, as opposed to that columnar ciliated epithelium, right? So that makes sense. Back to the papillomas. Inverted papilloma. Again, you see a lot of fingers on the inside. And in a fungiform papilloma, the fingers are on the outside, but you turn the sock inside out, and now the fingers are on the inside. Our third type and final type of Schneiderian papilloma is the oncocytic papilloma. This is characterized by a respiratory epithelium in opposition to the other two. You have a respiratory epithelium with microabscesses. So, yeah, that's a microabscess right there, you know. Seeing some believe those are neutrophils inside there. No, those aren't neutrophils. They have one nucleus. Maybe macrophages. Look like lymphocytes, actually. Might be helper T's. But all these washed out spaces within this respiratory epithelium, you know, particularly the big ones, you know, we said goblet cells are washed out, but goblet cells are shaped like a goblet, you know, like goblet of fire, like a cup. That's not a cup. That's a globe. So that's an abscess that we're looking at. And we're taking another look here. Beautiful histology. Lots of microabscesses within respiratory epithelium, although you can see a squamous epithelium too with the oncocytic. Yeah, I guess those were neutrophils on the inside of those abscesses. It's like, what else could they be, you know? Because what is an abscess? A bunch of pus. It gets there from neutrophils, and the neutrophils have proteolytic enzyme that chops everything up, and that's how you get liquefactive necrosis. And here is a little bit more zoomed in version of that. Again, you can tell that this whole upper layer here is very invested with micro abscesses, just fluid-filled packets, and they're going to have neutrophils in them. Let's move to olfactory neuroblastomas. I could see the question here coming like, what tumor presents similarly? Or what other tumor stains similarly, you know, because gives you some stains like NSE, synaptophysin, S100. And we've seen those. We had so many different tumors back in block 3 that it's like, where do you begin? There's medulloblastomas, there's ependymomas, there's neuroblastomas, there's peripheral neuroectodermal tumors, right? And so all of those are going to stain, like can stain enolase, S100. And then this part of the SDL here also mentions Homerite and Flexner-Wintersteiner rosettes, and we've seen a couple of different tumors with that condition. So let's dig into that real quick. Olfactory neuroblastomas are going to be on the roof of the nasal cavity. Remember, we're saying you can tell these tumors apart generally by their anatomical locations within the nose. In this case, what's at the top of your nose? Cranial nerve 1 that's connecting to all the olfactory neurons there. So if one of those olfactory neurons goes cancerous, then you're going to get a neuronal tumor, which is why it looks exactly the same as Ewing sarcoma, medulloblastoma with the small blue cells and the rosettes, you know. So it's like, okay, we've seen this before. This is just the nose version of it. So you're going to see it on the roof of the nasal cavity, and it can commonly invade paranasal sinuses. It can invade into upwards through the cribriform plate, through the anterior cranial fossa. So this is a bad tumor, and you want to get it out of there ASAP like Rocky. Let's look at the histology of these different rosettes here. Here's your Homer Wright pseudo-rosette. It's a pseudo-rosette. Why is it a pseudo-rosette? Because there's no true lumen. So you look for the lumen, and it would be right there, and it would be hollowed out, but it's not there. It's just fiber in the middle. So what other tumors do you see Homer Wright pseudo-rosettes in? You see them in medulloblastomas, which are going to be posterior fossa tumors, pediatric tumors. You see them in Ewing sarcoma, which is going to be an osseous tumor. That's got onion skinning, sunburst lesions, right? A lot of pain. Here are Flexner-Wintersteiner rosettes, and they are true rosettes because they do indeed have a true lumen. As you can tell, there's nothing in the middle there, no fibers, no neuropill, just a lumen. And you see Flexner-Wintersteiner rosettes very, very commonly. They're characteristic of retinoblastomas. So that's the associations that we've seen if they do get tested. Now we're going to talk about a nut midline carcinoma involving the NUT gene. Hard to remember. It's got a characteristic histology. It involves a 1519 balanced translocation, and the translocation creates an oncogene. So it's a gain of function of the nut gene that's going to lead to hypoacetylation of differentiation genes. So it's going to keep the cell stuck in growth, because when you differentiate, you're done growing, you know, and it's like neurons don't grow, and like cardiac myocytes don't grow. And it's like, why? Well, because they're very differentiated cells. They do very specific jobs. So if you stop a cell from differentiating, it'll just be stuck in the divisive stage. So that's how you get these tumors. They are fatal, really bad prognosis. They tend to be midline, again, nasal cavity, epiglottis, mediastinum, bladder, most commonly. And they've got this bad histology. We'll take a look at it here, in which you see a lot of small cells with scant cytoplasm. So we'll block off this picture one section at a time. You've got the small cells to the left here. Everything here is going to be your small cells. They're just very densely packed. They don't have a lot of cytoplasm to them. Then we've got polygonal squamous cells. And we saw some polyhedral squamous cells earlier, and these are going to be same concept here. Here you've got a bunch of them in the middle, and these are pancake flat squamous cells that if you were to zoom in really close, they've got, again, lots of sides to them. They've got a fried egg appearance, and they're just, in general, very out of control. They've got a ton of cytoplasm. And then finally, your large tumor cells are going to be everything else. So like this population outside here, bunch of large tumor cells. Everything on the right side of the screen really is going to be tumorous. And if you were to zoom in, you're going to see they've got really prominent nucleoli. And so I'll point that out for you. So where's a good cell? Where's good cell? Here's a good cell. So that whole thing that I just circled is a nucleus. And like this cell has almost no cytoplasm to it, very little cytoplasm from this angle. So this whole yellow thing is the nucleus, and then this dark area right there in the middle of it, that's your nucleolus. And then in this cell particularly, the fact that we see 1 and 2 nucleoli mean that this cell is replicating its genetic material. Here's another nucleus with cytoplasm around it. Here you can tell that's the cytoplasmic shape of the cell on the outside. And then use a different color here for the nucleolus. It's going to be right there in the dead middle of the cell. So those are the cancerous cells that we're looking at there. Back to the SDL. And we got a quick section about a cholesteatoma. I'm not going to talk about this at all because it's the only one in this whole text that involves the ear. Just know that it has the potential for kind of drilling in through the hole or through the temporal bone and opening you up for osteomyelitis or for meningitis, because right on the other side of the bone of the skull is going to be your duramater. Let's talk finally about the neck. 2 types of abnormalities here. They're not tumors. We're done with the tumors for now. You've got branchial cleft anomalies and you've got thyroglossal duct cysts. So where are these coming from? Well, your branchial cleft, if you recall, is going to be I must have took that slide out. Let's go to Google. Here we go. Yeah, this thing's your branchial cleft. Remember, we've got our pharyngeal arch derivatives, and the first and the second and the third each lead to different structures. And then you've got your arch and your cleft, and the arch is on the what is going to be the outside, and the cleft is on the inside, I think. And remember, it's going to be forming, was it week 28 or something of development? You're going to start to see this. Clefts on the outside, pouches on the inside, and the first one leads to the auditory tube. So the first one is going to obviously like cholesteatoma if there's a misformation there. Second one's going to give you your palatine tonsils, the thymus, and I remember that one now. The thymus, the third, and the parathyroid glands come from the third branchial pouch. And then you've got clefts 1, 2, 3, 4. And yeah, that's right. Your jaw arises out of that first cleft. So these are the branchial clefts that we are referring to. So if you have some sort of dysplasia in the development of these branchial clefts, you can get congenital cysts or fistulas, which is going to be basically a leakage of contents through the skin. It's going to be a tube that connects to the skin that drains outwards and doesn't close. So a type 1 anomaly of the first branchial cleft can present as a post-auricular or pre-auricular cyst. This is what it looks like. They can give it to you in a variety of presentations, either grossly or imaging. This is an example of a fistula, and this is going to be a type 2 anomaly of the first branchial cleft. Your type 1 is here, your type 2 is there. And you can tell that this one in particular is a fistula because, well, look at how inflamed that is. And then you can tell that it's got some sort of yellowy discharge in the middle there, right? And so you know that that's not like, it's not your belly button, because your belly button would be an example of a sinus, right? It's closed. But if your belly button just went straight through to your intestines, you know, that would be more like a fistula, which is an open communication. So pay close attention whenever she gives you the gross presentation on a test, because fistula, sinus, never know, might be asked. Here is a non-specific branchial cleft anomaly involving either the second, third, or fourth branchial clefts. This is a cyst at the anterior border of the sternocleidomastoid muscle of the neck. And it's non-specific because, again, an anomaly in either of these three separate arches will produce a cyst at this location. Here is a fistula at this location. Can't really tell if it's a fistula or a sinus, but you want to go with fistula just because you can notice some swelling up through there, some redness. And then we're going to talk about thyroglossal duct. We know that your thyroid gland starts off right beneath your tongue and that it migrates downwards as you age. And so if your thyroid gland doesn't travel down the midline of your anterior neck as it should, well, it can get stuck somewhere along the way. And if it gets stuck, if it gets stuck, here's a picture of it, like it's right underneath the tongue. So this person's got a thyroid gland at the bottom of the floor of their mouth. Shouldn't be there. Here's a thyroid cyst. So the thyroid migrates, and then when it migrates, it moves tissues out of the way. And long story short, as it migrates, you can get a cyst. So here's what one looks like. You've got to differentiate it from hyperthyroidism. Something like Graves' disease would cause an enlarged thyroid. Here's a sinus. I say that this is a sinus and not a fistula because we said the belly button's an example of a sinus, right? Because nothing leaks out of your belly button, and nothing's leaking out of this one. You can tell, in fact, it's quite dry and it's not inflamed. It's not red at all. And so you're more prone to call this a sinus. And that's all for the images that I have. Let's finish up the SDL. Second branchial arch anomalies are the most common and account for 95% of cases. And those second branchial arch anomalies are going to present right there at the anterior border of the sternocleidomastoid. It can be a cyst, a sinus, or a fistula. And again, this is most likely going to be a source of much ambiguity on an exam question. The cysts tend to be unilocular and lined by stratified squamous. And what's going to be the internal material of that cyst? Well, if it's pustular, it's going to be neutrophils, although it can just be a normal exudate. Fistula and sinuses are diagnosed earlier than cysts, owing to the more obvious presence of pain discharged from a skin opening. Type 1 anomalies are going to be the real one that you have to differentiate because it's the only one with it. Well, the first clef anomalies have a type 1 and a type 2. Again, second, third, and fourth branchial arch anomalies present almost identically. Then we talk about the thyroglossal duct. And again, it starts right there, then it goes down, down, down. So it starts right under your tongue, then it migrates down the midline. And whenever somebody has a thyroglossal duct anomaly and you recognize it, you're going to want to take it out unless it's tiny and just totally benign. So that was tumors of the head and neck. That was our first of, I think, 3 different tumor lectures for this particular exam. And just based off the categories, you're going to get a question about an odontogenic cyst. You're going to get a question about an odontogenic tumor. Probably going to get 2 questions about growths in the nasal cavity. Then probably going to get a gross question about the anomalies of the anterior neck. And if we get asked about a cholesteatoma, man, they better not, because it's like, again, it's the only thing in this text that has anything to do with the ear. So, oh well. See you next time.